team. First, I would like to thank my professor, Dr. Mamdouh Gabr, Dr. Khalid Zarrour, Dr. Abdul Raouf, Dr. Luay, and all other my professors. Today we will talk about malnutrition in cirrhotic patients. This is the main points we will talk about. First, introduction. Nutrition has long been recognized as a prognostic and therapeutic determinant in patients with chronic liver disease. The liver is an important regulator of metabolism, storage, synthesis, and absorption of nutrients. Accordingly, the severity of malnutrition increases with the decrease in liver function. Improvement in nutritional status can improve the outcome of patients with advanced liver disease. Malnutrition should alert clinicians to the same extent as the presence of other common complications of cirrhosis such as hepatic encephalopathy and ascites. The original child-Telcott classification, which was used up to 1973 to assess the prognosis in end-stage liver disease, includes the nutritional status in its criteria, whereas the modified child-Buck classification has replaced it with prothrombin type. Definition of malnutrition in cirrhotic patients. Patients with chronic liver disease become malnourished when they have an inability to meet macronutrient and micronutrient requirements through oral intake. Prevalence. Malnutrition is common in patients with advanced liver disease. The prevalence is reported to be 50% to 90% among cirrhotic patients. In one study, 95% of child Buck class A presented with malnutrition, while 84% and 46% of class B and A respectively. 65% of malnourished patients developed complications such as infection, hepatic encephalopathy, ascites, and hepatorenal syndrome, compared with only 11% of well-nourished patients. Malnourished child Buck class A had a one-year mortality rate of about 20%, whereas none of well-nourished patients died within the one-year period. After liver transplantation, malnutrition has been associated with higher rate of complication and mortality. The etiology of malnutrition. The etiology of malnutrition is multifactorial and related to reduced liver function, poor oral intake, and the complication of cirrhosis such as ascites and hepatic encephalopathy. Number one in the etiology is hypermetabolism. Resting energy expenditure is the amount of energy an individual uses to perform vital organ functions apart from the activity and digestion. Hypermetabolism is defined as resting energy expenditure more than 120% compared with the predicted value. From 15% to 30% of cirrhotic patients are hypermetabolic. It may be result from increased plasma concentration of catecholamines, indicating activation of the sympathetic nervous system. Sympathetic overactivity induces systemic responses such as tachycardia, increased cardiac output, and glucose levels. Proposed cause of increased these levels of catecholamines include gastrointestinal bacterial translocation, inflammatory phenotype of chronic liver disease, central neural dysregulation of the circulation. Number two in the etiology is malabsorption. Multiple mechanisms that can lead to malabsorption of nutrients, particularly of fat. Number one, poor systemic shunting causes nutrients to bypass the liver without metabolic process. Number two, alcohol abuse causes chronic pancreatitis. Number three, interluminal bile acid deficiency, which results from decreased capacity of bile production and poor systemic shunt, impaired formation of micelles and absorption of long-chain fatty acids through the usual lymphatic route. Bypass standard lymphatic transport with a portal route for fat absorption could result in excess hepatic storage of fat, which can reduce the liver function. Number three in the etiology of malnutrition is anorexia. Anorexia can cause by number one, physical symptoms like nausea, bloating, fatigue, vomiting, and patients with ascites often experience early satiety resulting from the mechanical compression on the stomach. Number two, patients with cirrhosis have increased level of the tumor necrosis factor alpha, which may affect appetite and metabolism by acting on the central nervous system, altering the release and function of neurotransmitters. Number three, cirrhotic patients have twofold increase in fasting level of leptin, Compared with the healthy individuals, this might contribute to anorexia in these patients. Changes in the level of ghrelin hormone also. Number 5, this interest in food from dietary restrictions and taste alteration. Number 6, alcohol-related anorexia. Number 4, in the etiology of malnutrition, altered macronutrient metabolism. Cirrhotic patients have increased level of gluconeogenesis and protein catabolism, and decreased level of glycogenolysis. Gluconeogenesis is the formation of glucose from fat and proteins, and the glycogenolysis is formation of glucose from glycogen, which reflect a significant depletion in protein and fat reserves in about 50% of cirrhotic patients. Cirrhosis reduces the ability of hepatocytes to store, synthesize, and break down of glycogen. These defects promote gluconeogenesis from fats and protein as alternate fuel sources. Patients with cirrhosis have high serum level of insulin. This insulin resistance decreases peripheral glucose utilization and contribute to decreased hepatic glucose production. Increased serum level of glucagon, which results from impaired degradation of the liver to this hormone. Increase the level of gluconeogenesis. The production of cytokines and other infection mediators like tumor necrosis factor activate proteolysis and increase oxidation of the branched chain aromatic acids. This can promote breakdown of muscle cells. Number 5, the micronutrient status. Number 1, zinc deficiency. It occurs in patients with ascites due to restricted intake of animal protein and from diuretic use. Number 2, magnesium deficiency, which can result from diuretic intake, use of diuretics. Number 3, fat-soluble vitamins deficiency, vitamin A, D, E, and K. In one study on 180 patients with primary biliary cirrhosis, 33%, 13%, and 2%, and 8% has deficiency in vitamin A, D, E, or K, respectively. Those can also impair absorption of other nutrients such as vitamin D and calcium. Number 4, vitamin B1, B2, B6, and folate. Hepatitis C virus infection associated with decreased vitamin C and folate. Therapy with becylate interferon and ribavirin decrease vitamins B1, B2, and B6. Hepatitis C virus may compete with human cells for vitamins. How we nutritionally assess the patient? We have 3 methods for nutrition assessment. Number 1, subjective global assessment. It's a chart in which we assess the dietary intake, weight change, eye symptoms, and examination of subcutaneous fat loss and muscle wasting, edema, and ascites, and it is cost effective. Number 2, it's the traditional method is the anthropometric analysis. It measures the weight, mid-arm circumference, triceps skin fold thickness. Number 3, the hand grip strength test. It's used certain apparatus called dynamometry. It's simple and a quick tool to assess the nutritional status. What is the nutritional recommendations? The aim of nutritional recommendation is to provide patients with cirrhosis with sufficient energy intake for daily activity, to prevent further protein catabolism for energy, to meet nutritional macro and micro requirements. Number 1, the recommendations about the calories. All the energy recommendations is dependent on the patient dry weight. In the presence of ascites, we determine the ideal body weight of the patient. If the patient without encephalopathy, the recommendations is 25 to 35 kilocalories per kg per day. In patients with acute encephalopathy, 35 kilocalories per kg per day. In a stable malnourished patient, 30 to 40 kilocalories kg per day. Nutrition recommendations about carbohydrates. Carbohydrate restriction isn't recommended for patients with cirrhosis, despite the high prevalence of insulin resistance and diabetes in this population. But with impaired glycogen synthesis and limited glycogen stores in the liver, regular intake of carbohydrates can help prevent hyperglycemia and gluconeogenesis. Patients are advised to have frequent meals and snacks to reduce the risk of hypoglycemia. It has been recommended that carbohydrates account for 45 to 65 from the total calorie intake per day. Nutrition recommendations about proteins. Studies have shown that high protein diets are not only well tolerated in patients with cirrhosis and moderate hepatic encephalopathy, but can also improve their prognosis and mental status. Conversely, protein restrictions can lead to increased protein catabolism, which worsens the hepatic encephalopathy because of the release of ammonia, which is a product of catabolism. All patients except acute encephalopathy recommended to take from 1 to 1.5 gram per kg per day. In acute encephalopathy, 0.6 to 0.8 gram per kg per day. Nutritional recommendation about fat. Although several mechanisms appear to contribute to fat malabsorption, there are no guidelines to support the use of medium chain triglycerides for patients with cirrhosis. Fat recommendation to be from 25 to 30% of daily caloric intake. Recommendation about vitamins for patients with advanced liver disease. Diet supplementation with fat-soluble vitamins A, D, E, and K, zinc, selenium are recommended. About the sodium, patients with ascites and edema restricted to less 2 gram per day sodium intake. Recommendations about probiotics. 25% have small bowel bacterial overgrowth, which can promote intestinal wall permeability that result in bacterial translocation, secondary infection, and fat malabsorption. Probiotics may improve minimal hepatic encephalopathy by lowering intestinal level of ammonia and decreasing pH, which will inhibit the growth of pathogenic bacteria and decrease intestinal permeability. Recommendation about the branched chain amino acids. Ammonia and aromatic amino acids are normally metabolized and detoxified by the liver. Branched chain amino acids are amino acids that are essential for protein synthesis. Patients with cirrhosis have a low ratio of branched chain amino acids to aromatic amino acids. Branched chain amino acids and aromatic amino acids compete for same blood-brain barrier transporter, so decreased serum concentration of the branched chain amino acid, increased brain uptake of tryptophan, which is a type of aromatic amino acid, which cause an imbalance of neurotransmitter synthesis in the brain, leading to hepatic encephalopathy. Branched chain amino acid supplementation can reduce the hyperammonemia because ammonia is detoxified as a part of the skeletal muscle metabolism of branched chain amino acids for energy. The last point in the nutrition recommendation is nocturnal supplementation. In one study, there is a significant increase in total body protein stores over 3, 6, and 12 months period in the group given bedtime supplementation, which attributed to the decreased length of the overnight fast and decreased nocturnal gluconeogenesis. Branched chain amino acid rich snack significantly improve serum level of albumin. This study indicates that bedtime supplementation can shorten the length of overnight fast and improve protein stores. In summary, malnutrition is prevalent among cirrhotic patients. Number 2, etiological factors include hypermetabolism, malabsorption, altered nutrient metabolism, and anorexia. It's important to accurately assess nutritional status and provide nutritional support. This task is challenging due to the complication. In addition to the current recommendation for macro and micronutrient supplementation, the therapeutic use of nutrients such as branched chain amino acid and probiotics are hopeful. And thank you.